Hello everyone from Straub Medical. Here connected with us there is Kenneth Brown and Professor Romaric Lofra. Hello guys, how are you?
Very well. How are you doing, Sergio?
Very well, thank you. Very
Fine.
well. And actually, let me welcome our audience. We are here for the first time to present our NESTS webinar, which is a new series of webinar. NEST stands for Never Stop Sharing. Actually, the idea behind it is that we are here quarantined at home since actually 5 weeks now in Italy, and we are actually getting ready to fly again. So this is the purpose of this webinar: sharing experience with super experts, sharing knowledge with them. And today will be the case of DVTs. So we will discuss about DVTs, touching different aspects, and actually here, almost about to join us, there will be also Dr. Bruno Freitas from Brazil, which is now arriving from the Cath Lab, as Dr. Thomas Heller. So we are expecting them in the next few seconds, hopefully. So we are almost ready. So again, with us, Kenneth Brown, Manager of Education and Training Physician, and Professor Romaric Lefra from University Dijon. So how are you, Professor Romaric, today? Everything's fine?
Yeah, fine, perfectly. Thank you very much for invitation. It's very nice to be here.
Yeah, thank you for accepting our invitation. We also tell our audience that they can also connect through mobile or tablet, and they can just swipe on the screen to change their view from the presentation to the webcams to the other features of the platform. I would now start maybe sharing Professor Lofra presentation, and I think we can give you the commands of the platform. So feel free to start whenever you like.
Okay, perfect. So thank you very much. Good afternoon, everyone. It's my pleasure to be part of this. So very nice to share our experience with the use of Asprex in iliofemoral DVT, especially in this very bizarre context in Europe and in world. So I think it's a very good idea to share and to discuss about that. So let me just share with you our experience about the use of Asprex for this, and with a retrospect. Maybe you can get next slide.
You can also do that if you like. Probably it will take a couple of seconds. Okay, I will.
Yeah. Okay. Next. Okay, perfect. So as you know, and better than me, we have different options now currently available in the market for thrombectomy. I mean, from standard thrombolysis to different mechanical thrombectomy devices, and the two ones, the last two ones, pure mechanical thrombectomy devices, and Digo from Penumbra and Asprex S, which is a rotational mechanical thrombectomy device, and this is one of the advantages, that then we don't need any additional lytics in most cases, at least no infusion of lytics for this kind of device and for this kind of patient, reducing, of course, the risk of bleeding complication. Next slide, maybe. So the goal of our study and what was to assess the safety, the technical success, and the clinical efficacy of mechanical thrombectomy for acute, symptomatic, of course, all the time, iliofemoral deep vein thrombosis using the Asprex device. So it comes in 3 different sizes, 6, 8, and 10 French, with the helix, as you can see on this picture, at the tip of the catheter, which is supposed to aspirate with a huge capacity of aspiration, especially for the 10 French, and that's the one we use for iliofemoral DVT, and with a very small generator. And this is the second advantage of the device, in comparison with other devices. The very small generator, which makes the procedure very easy in clinical practice. So next slide, please. So it was a single center study from 2015 to 2019 with 30 patients, mainly women, mainly young women. As you can see, the mean age 45 years old, and half of them had a DVT history, and 20% some thrombophilic abnormality. All patients were symptomatic with swelling and pain, and additional pulmonary embolism in 3 patients, and all patients, this is our protocol now, got systematic ultrasound and CT, not all only CT of the abdomen and the legs, but also to check any pulmonary embolism. This is very important in this context. Next slide, please. In terms of DVT characteristics, the side involved was the left side in most cases, of course. Localization, if we look at this classification, the lower extremity thrombosis classification, lead free in 25 patients with involvement of the popliteal vein in 6 patients from them, and lead 4, meaning with involvement of the IVC, 5 patients. The duration of symptoms, as you can see, 5.5 days, and this is a take-home message that I want to share with you, is to do this kind of procedure very quickly after onset of symptoms. This is very important to make sure that the thrombus is fresh and that we can remove thrombus as much as possible. And the etiology, of course, was Meissner syndrome in 2/3 of patients, as in most of series, of course, because this is the main cause. Next slide, please. So we performed all procedure on the local anesthesia. The endovascular approach was the popliteal vein as much as possible. This is my preferred one. Of course, if the popliteal vein is patent, which is not always the case, but if this is the case, this is my preferred approach, because I mean, we can discuss about that at the end, but we are in the direct and the right flow, and we don't have to manage long catheters and guide wires, and it's always easy. So many advantages, some drawbacks. We will see that, but in most cases, it can be very interesting. We used always the Aspirex 10 French with only one length, with a temporary IVC filter in almost half of patients. And I would say that in the second part of the study, we use now more and more systematically a filter. I don't know if it's absolutely mandatory for every case, but let's say that it can be like one more protection. We will be able to discuss about that with all of you guys. But this is our protocol now, and the post-operative medication for 3 months, a combination of anticoagulation and antiplatelets at least for 3 months, and then according to thrombophilic abnormality, underlying disease, we have to discuss later about that. Next slide, please. So this is the device, and as you can see, this is the 10 French with the helix at the tip of the catheter with a huge capacity of aspiration, 4,000 rotation per minute and 130 milliliters per minute. So meaning that you have to keep an eye on the collecting bag because you can really remove a lot of thrombus, and that's the key point. Maybe next slide. Okay. Okay, so let me show you some examples here. An example of a bipopliteal approach here on the left side. Next, you can see the iliofemoral extensive thrombosis. Next, as you can see, the catheter is inside here, and we have a lot of thrombus to remove. Next, and then you can see the return flow in the IVC. Next, and then after 2 runs of Aspirex, in that case, you can see the result. Next, we can unmask the underlying lesion at the proximal port, which is a stenosis as usual, I would say, that we treated next with stenting at the proximal port, but also at the the femoral level in that case. Probably now I will not do this at the femoral level because anticoagulant medication can really do the rest of the job. The main thing is to restore the flow, to remove thrombus as much as possible, and then to stent the underlying lesion, which is the case in almost all patients. Next. And this is the final result, as you can see. So technical successes, we consider a restoration of proximal iliofemoral blood flow and residual thrombus less than 20% was 100%, with no lytic therapy infusion on the long term, stenting rate 100%, and this is the difference. And this is one, I think, of the limitations of the ATTRACT study. If we discuss about that at the end, we have to stent almost all the time. Number of aspirates runs 2.6 per patient. You can see that thrombus aspirated mean almost, around 300 milliliters, and the mean procedural time in terms of PMT run less than 5 minutes, which is quite easy and quite short, and the overall total procedure 100 minutes. Next. So clinical success 90%. If we consider relief of acute symptoms within 3 days with no major complications, only 2 minor complications at the beginning without any consequence. Hospital said 2.6 days. Most of patients were discharged within 2 days. And what is very important is the patency rate at 6 months, 90%. The primary patency rate with early instant thrombosis within 1 week in 3 patients that we treated again with Aspirex. And the secondary patency rate of 86.7% with failure of recognition in 2 patients because chronic occlusion, instant chronic occlusion in veins can be very challenging to treat, and no recognition was attempted in 2 patients because they were not very symptomatic at the end. So we decided to not doing anything. The PTS at 6 months, low in most of patients and moderate only for 8 patients at 6 months for all patients overall. Next. Another example here of LET4. You can see the thrombus in the IVC. So in that case, of course, we use the jugular approach with a filter, and then we pass through the filter with the long sheath. As you can see here, you can see the thrombosis, which is extensive, the iliofemoral thrombosis. Next. And even at the femoral level. Next. And on the guide wire, a 25-inch guide wire, then we aspirate. Next. It's very easy. We cannot damage the valves. You can see the stenosis at the proximal part as usual. Next. And then the stenting, and then the final result. Next. As you can see here, and in that case we didn't put any stent at the femoral level because anticoagulant medication did the rest of the job, and the proximal flow was restored, which is the main goal to me. And this is the take-home message for this. Next, maybe. Another example here of one of the first patients we treated on the right side, a patient with a previous history of IVC ligation, total IVC ligation for oncologic reasons, and you can see next the extensive thrombosis at the iliofemoral level with the proximal part draining into collaterals. Next. Explaining, of course, the DVT on this side. Next. Lumbar collaterals, as you can see here. Next. And then aspiration. Next. You can see the result after aspiration, which is not perfect, but we can remove a lot of thrombus, and then we decided to stent this part. Next. As you can see here. Yeah. Next. And then the final result, and still patent this patient, very surprisingly, but still patent in the long term, thanks to, so even in very exotic conditions, I would say, you can use it, and probably Thomas will show us some very specific territories that we can treat also with the device. Next. Another example, maybe quickly, on the left side, the same thing. Next. You can see by jugular approach again. You can see again. Next. complete thrombosis, extensive thrombosis. Next. And even at the femoral and popliteal level, you can see here. So we try to avoid as much as possible to stent this part, but at least to remove the thrombus and then to stent the proximal part. Next. You can see on the guide wire, the aspirates which is running on the guide wire here, very easy to use. Next. Yeah, and the final result. Next. Next. Again, stenting. Next. Next. And this is the final result. In that case, after extensive stenting from the IVC to the femoral level, I mean to the common femoral level, which is not always necessary, but sometimes you need to do this. Next. Again, by popliteal approach, in that case, always the same kind of situation. Next, complete iliofemoral thrombosis. We pass through with a standard catheter, then we put the guide wire, and then we start to aspirate. Next. With the device again. Next. And in most of cases, you have to pay attention at the level of the stenosis, because you can, when you run the device, anyway, you can hear some noise, meaning that you have a stenosis, and then you treat the underlying lesion, as you can see here. Next. And you can see the result, and with a small thrombus still in the iliac external vein that we treated with aspiration again after treatment. Next. And this is the final result with the stent, which is patent on the control, with very nice result. Next. Again. So it can be very interesting. Of course, the catheter has a cost, a specific cost, but we have to take into balance the speed of thrombus removal. We don't need any ICU stay, no angiographic control, no lytics, so no bleeding complications. And when we calculate the cost of a procedure, we have to calculate everything, of course. And you can even do this kind of procedure as an outpatient procedure. Let me show you the next example and the last one about the use of the device. Next, in a patient, we got a call from the angiologist in the morning. We did the CT. Next. And the angio suite in the afternoon by jugular approach with a filter, always the same thing. Next. Maybe we can go more quickly. Next. Thrombosis, pass through with the guide wire and then aspirate. Yeah, next. This is the device, the 10 French device, and stenting at the proximal port. Next. And you can see the final results. Next. With ultrasound control at 1 day, everything was patent, and the patient was discharged the same day. So it can even be done as an outpatient procedure in some very specific cases. So in very selected patients, of course, because no risk and no bleeding complications. Next. So some limitations of the study, but as usual, maybe we can skip this slide. Not very interesting. Just to say that there is an ongoing PMAX study in Europe with some centers about the use of, this is a post-market study about the use of Aspirex for different indications, and Thomas is participating too, and we are several to participate, and it's very interesting to participate to this clinical follow-up study. Maybe next. So in conclusion, I would say that this is very efficient, very safe, very fast to remove thrombus, to restore the vein patency, to allow for treatment of the underlying lesion by stenting just afterwards, and to prevent as much as possible the risk of PTS, and very easy to manage with this kind of device. Maybe next, I put some questions that we can discuss and share with Bruno and Thomas about the use of what is the best approach. What do we need to put an IVC IVC filter every time? Do we really need to remove 100% of thrombus, which is in most cases not the case, but we don't mind if we restore the flow? What is the best landing zone for stenting, and the protocol we can use in terms of anticoagulant medication? I don't know if we can discuss about that.
Sure. And first of all, thank you very much for your very interesting presentation. And let me introduce you to our audience, also from Maceió, Dr. Bruno Freitas. Hello, Dr. Bruno. How are you?
I'm fine, Sergio. Hello, Homeric and Thomas. I'm glad to join you guys.
And from the University of Rostock, I see you are still in your uniform, Dr. Thomas Heller. How are you, Dr. Thomas?
I'm fine. How are you? I hope
Fine, thank you.
In Italy, we know
it's tough. We are all closed here, plenty of time to organize webinars, so we have a lot of fun with this right now. I think you brought up many interesting points. We start to have an interesting question from the audience. Let's go, I would say, step by step. First of all, you described a transjugular approach to a DVT. We well know, and these questions are comes very often to us. You know, sometimes the fem vein is already occluded. Sometimes even the popliteal vein is occluded. So I think this is an alternative approach. First question to you, Dr. Romaric. At the end, what would you suggest and would you recommend in this technique, which is different to a standard Aspirex approach?
Yeah, honestly, my preferred approach, if the popliteal vein is patent, is to go through the popliteal vein, because you are in the direct flow. You can control. You have a real-time feedback on what you are doing. You don't have to change for another guide wire and everything every time you want to check. The only drawback of this approach is that you cannot remove any thrombus in the profunda. So if you want to make patent the profunda, you have to go through the jugular approach. The Aspirex device is long enough, usually, except in very tall patients, but is long enough to go up to the popliteal vein by jugular approach. I mean, this is 110 centimeters in length, which is in 90% of patients fine. And of course, if you have a late 4 DVT, meaning involvement of the IVC with thrombus in the IVC, of course, we prefer the jugular approach in that case, because we have to put a filter. That's my approach. I mean, we can sometimes it can be bilateral. It can be both approaches. I mean, because you need to put a filter first and then to go through the popliteal vein. So depending on the situation, the patient, you can choose. But now mainly we do popliteal approach.
Okay, and one technical question. You know, normally we would recommend an infusion to treat a patient with Aspirex through the introducer sheath. From transjugular approach, are you maybe using a long introducer sheath? Are you infusing, or you think there is less need of an infusion compared to a standard retrograde approach?
Yeah, anyway, we always put infusion. It's always better to make sure that we don't stick any, I mean, the helix on the guide wire and everything. It's always better to put infusion with heparin inside whatever the approach, I would say. But probably it's even more important by popliteal approach, of course.
Okay, I will ask Dr. Bruno also to give his opinion about, you know, what other alternative approach may we use in case of a popliteal which is full of thrombi?
So thanks for the question. Actually, as this device works on a principle of like a pump, we need to have some kind of inflow so that it can work properly. And as we are using the Rotarex device, we have the inflow coming from the arterial tree. So this is satisfied. But as we are treating on the venous level, and we need Aspirex to have some kind of good inflow. And this is why I agree completely with Homeric. I mean, you need to have some good inflow. We use normally a solution which is divided in 4 parts. 1,000 saline, we use 750 saline solution and 250 contrast medium. Nevertheless, sometimes we use the offspring of the external saphenous vein when it's opened, and we try to puncture over there and try to insert initially a small 11 French sheath from it so that we can have access. And as we progress, we exchange this 11 French sheath short to a longer one from Cook or from MSB. We have the 11 and 12 French sheath. And this is important because sometimes as you are moving upwards, the inflow, the contrast that you are infusing is completely, or the vast majority, aspirated by the device. So you don't need to worry about contrast-induced nephropathy. But sometimes you do have some stealing collaterals that can steal the contrast and take it to the common circulation if you're using only a short sheath. And this is why we like to work with a longer sheet coming by together a little bit with the device, avoiding to lose contrast in the common circulation. So this is for us very important. Another important aspect is that it is important to keep the iliofemoral segment free. And after that, you need to have good inflow. So having an open profunda is essential, a good open profunda. So if you can't assess it adequately per ultrasound, if you think it's closed, we normally try to puncture contralateral right after the procedure and clean the profunda also with Aspirex through a contralateral approach. When this is not possible, we go for open thrombectomy. When this is not, rarely, when the patient is chronic and we do not have a good inflow, then either on the same day, maximum on the next day, we go, especially on acute on chronic patients, we go for arteriovenous fistula. That can be done to the common femoral artery or to the profunda artery, or you can use also the saphenous vein to do this arteriovenous fistula. But this is all to guarantee that you will have a good flow. If you don't have a good inflow, everything that you do will be lost very quickly.
Yeah, I fully agree, and thank you for sharing this. Dr. Freitas, I ask you to share your presentation. In the meanwhile, I'll ask Dr. Heller if he has some comments on this, on different approaches, and I think that we will keep another hot questions, which will be on stents after Dr. Bruno Freitas' presentation. But in the meanwhile, please, Dr. Thomas Heller.
Yes, we sometimes choose a little bit different approach because when we or I talked to our vascular surgeons, they said to me that if the popliteal vein is already occluded, they melt the calf to bring the thrombus up if they do perform open thrombectomy. And in some cases, where there's a real acute clot, we puncture the popliteal vein even if the popliteal vein is occluded or affected by the thrombus. And then we do the same. We melt the calf to bring the clot up to the sheath and to the device. And with the additional infusion, and this is very important to lower the viscosity, we can remove, I think, more clots from the calf and from the popliteal vein, like a surgeon, and then we clean up the upper part. And I think we all know that the calf veins have a very high capacity of spontaneous or natural clot removal. So in some cases, if you treat a young woman, she's afraid of the jugular puncture, you see the scar, and sometimes we have to puncture. This is another, I think, interesting question to Romaric. If we use a IVC filter, we remove the filter in the same session, not to have a second puncture in the jugular vein. So do you do the same, or do you remove the filter after 2 weeks or 3 weeks or 3 months?
Yeah, usually we remove the filter later, usually between 1 and 2 months. I mean, just to make sure that everything is. I mean, but I'm not saying that this is I'm right, but I mean, we try to do this later in case of any thrombus, you know, during the procedure in the filter, to make sure that we don't get any migration and everything. But I don't know, but probably it can, if we use the, I mean, Strobe Medical is making a specific filter for this, the Capturex. Of course, if you use it, you have to remove it because you cannot leave it in the IVC. This is connected to the catheter, so you put the catheter and the filter. It can be very interesting, but we usually put a ELN filter, and we remove later. Yeah.
Okay.
Okay.
Just another question before we go on, just on filters.
Thank
What
you, Ken.
indication do you have for filters? Any specific type that you would recommend? And I think we've already answered the retrieval. Do you have any specific indications, or just for every iliofemoral DVT you're treating with Aspirex?
In Rostock, we use the filter if there is if the head of the clot is in the infravena cava, or
Okay.
if the patient already has a pulmonary embolism in some cases, or if the patient is afraid about pulmonary embolism and ask for a filter. So that are our main indications.
Let's launch
you.
a poll to our audience. So in the meanwhile, we can also gather their opinion on this. Please go ahead with the answer. If you like to add, Dr. Freitas, something.
So
to this.
I pretty much enjoy it. Well, it's not a point of enjoying, but I pretty much agree with Thomas' position. At the beginning of our experience, we used filters in all the procedures. We use angio-CTs previously to those interventions. And normally when we do have thrombus in the cava, floating thrombus into the cava, when we do have patients with previous pulmonary embolism, we do use regularly filters. We do not have here in Brazil Capturex. I would love to. But on the other hand, as we implant a filter, we really enjoy leaving it for a while. We've had a couple of patients that presented with pulmonary embolism on early postoperative period, especially when we're not able to take all the thrombus from the infrainguinal segment. You can have further embolizations, and then this can be quite, let's say, dangerous. So we leave it for a couple of weeks, a month, and then we take it out. When we do have a Cockett syndrome, for instance, a very compressive Cockett syndrome, which is really in the ostium of the common iliac vein, then we don't see it's necessary to implant a filter, because in our opinion you're able to move slowly, steadily, and very calmly, and you can take everything you need to take out, make a control before coming to the proximal part, so that at the end of the day not even the catheter sometimes can pass so freely. So we don't use filters in all the procedures, but in those procedures, just like Thomas described.
Thank you very much.
Would you like to add something, Dr. Lefroy, or shall we go to the next presentation?
You can go on.
So, Dr. Freitas, you can go on with your presentation. We have a lot of questions. We hope we will answer each of them during our Q&A session at the end of the presentation. Now let's move ahead with Dr. Freitas.
So guys, thank you very much. I think it's an honor to me to be together with Romanik and Thomas, a very experienced guy, top guys in this segment, so it takes the discussion a little more pleasant. So we'll talk a little bit about our experience, make some share some thoughts that we have. This is our group. I would just like to mention that the mid guy here is Elton. Today is a sad day for us. His dad just passed away in a few minutes ago. He had a ruptured thoracoabdominal aneurysm, so our prayers to him. As we think about venous obstructive lesions, we need to make it a little bit more particular. What kind of context are we talking about? We're not going to talk about here about chronic post-DVT patients or primary non-occlusive May-Turner syndrome. We will focus on acute DVT, iliofemoral DVT patients. And we think that the medical treatment in many situations, they are mostly insufficient. So the surgical treatment, normally the open surgical treatment, is very invasive, very crude, and sometimes have many deceiving results. So if we think about the other the treatments itself, best medical treatment with no in stockings, we know that we can have up to something like 60% of chronic venous hypertension symptoms. If we think about catheter directly aspiration, especially looking at the iliofemoral segment or long occlusions from the inferior vena cava to the POP segment, catheter directed aspiration is just not effective. It's an unendless procedure. Catheter directed thrombolysis is something that is highly, let's say, known worldwide, but we know also about effectiveness issues and also about safety issues, though, and also about it's an inconvenient treatment, since many times you need to stay for 12, 24, or even more hours doing fibrinogen dosages that are not very reliable in many centers. And also, you're not taking care of the patient all the time. He needs to go to the ICU. If we think of pharmacomechanical thrombectomy devices, just as the angiojet, for instance, we know that's a bulky device. We know that we have a lot of issues regarding to hemolysis, regarding to acute tubular necrosis, and this is an issue, especially with massive thrombosis. And also, the best optimal time to use this kind of device is, let's say, 4 to 7 days. Nothing more than that would work properly. So because of that, and if we think of vacuum thrombectomy devices, we have an issue regarding to effectiveness and the time of the procedure. So we really believe, in our experience, that mechanical thrombectomy can be very reasonable and good options. And why? Because we think it's a fast procedure, because it's a single session procedure that solves the problem, because we think that with a very fast, let's put it like this, learning curve, it's a friendly use. You don't have to worry about many things. You need to just mentalize and memorize the concept, the main concept, and follow some important steps, and it'll work in a very reproducible manner. It's a very effective tool, and you can avoid thrombolysis in the vast majority of patients. And even when you need to use, you're talking about a very low dose, single bolus dose of thrombolytics. If we think of the ATTRACT, Homaric just mentioned some of the singularities of ATTRACT. I would like to mention some else's. If we think about femoral popliteal DVT, we all know that it makes no sense to open the femoral popliteal, to treat the femoral popliteal DVTs in terms of long-term patency, in terms of ulcer healing, in terms of precluding chronic venous hypertension. Even though in the ATTRACT trial, we had 43% of the patients analyzed for femoral popliteal DVT. There was no clear definition criteria for stenting, so many patients were not stented at all, and 59% of the patients which were stented received non-dedicated venous stents. We know that I'm not an advocate for IVUS free use or liberal use in arterial segment, but I'm convinced that it is important to use necessary. Even the word mandatory would not be exaggerated as we treat endovenous patients, since a very big amount of patients have proximal compressions, and you need to analyze whether they are present or not, and the importance of them. So if we think about the recurrent DVT rate, and this I would like to highlight, And as we think of the follow-up period, you can have up to a third of those patients that will come with another DVT if you do only best medical treatment. We know that we do have a 2 to 3 week treatment window, and with Aspirex, we can treat up to patients up to 14 to 21 days very effectively. If we think about this young patient, female patient, athletic, with a descending iliofemoral thrombosis, with main-Turner syndrome diagnosed by an angio-CT, you can think about thrombolysis if you want. She's healthy. It's inconvenient. It'll be long-lasting, but you can think of this. But what about this patient? He's 61-year-old. She's 61-year-old. She says she has a phlegmasia cerulidolens, a massive iliofemoral thrombosis encompassing the inferior vena cava, and 1 month ischemic stroke. So I would say this is a patient with a high risk for catheter-directed thrombolysis. And we think that this is a patient that we can offer a very good effective treatment with Aspirex thrombectomy devices. In May-Turner syndrome, a pure May-Turner syndrome occlusive with no occlusion of the Penfold segment, we can use the common femoral vein, the great saphenous vein, or we can use the POP vein, the popliteal vein, or the external saphenous vein in patients with acute massive thrombosis, just like that. We do the puncture is ultrasound assisted. After we do the catheterization, normally we deal with the lesion with a normal mammary catheter and an O35 guide wire. Then after obviously the initial angiograms, and then we go for the Aspirex passage or passages, and after that we go for pre-dilatation, not obligatory in all the patients, depends on how it appears for us, stanton, and then post-dilatation. So on a patient like this is the patient that we are talking about. This is a phlegmasia cerulidolens, massive phlegmasia cerulidolens. We would go with the patient in the ventral position. We would go for ultrasound puncture, as we can see here on the guide wire going in. I hope you guys can see. And we do have followed up to 1 year, 41 patients. In total, we already have 60 something, but most of them are female patients. Half of them smoke. 70% of have dyslipidemia. 5% of those. We see that 65% of the patients are acute, less than 14 days, but we do have a fourth of patients that have more than 14 days. Our vast majority of patients, 33 patients, they do have a very long thrombotic scenario. So we're talking about real challenging patients, and more than 80% of the patients we had to implant a stent, either because of a May-Turner or Cochrane syndrome, or because we were treating acute on chronic patients that needed some support, scaffold support. We use normally only 5,000 heparin. We rarely use thrombolysis with a slow dose of thrombolysis. We are talking about a fast procedure, and we use IVUS in all of the patients. In terms of primary patency, we achieved a very good result, I would say, of 92.2% of the patients. And if we think about secondary patients, we could maintain those patients with a good status in 100% of them. In terms of perforation, we had only one patient that had a perforation with the guide wire. 3 patients had a bleeding, but no chirurgical bleeding, only small hematomas in 2 patients, and in 1 patient we did have a perforation of the guide wire, but that was self-limited. We had 6 pulmonary embolism that I would like to explain. In our department, we are running a study for thrombectomy devices, Aspirex, and pulmonary embolism. So we do document all the patients for pulmonary embolism. And as we see, we only have clinically relevant pulmonary embolism in 2 patients. The 4 other patients were only incidental findings in the tomography, but only minor peripheral. We had 3 patients that died, but none related to the device. 2 of them had myocardial infarction. So just to finalize here, I would like to show a 39-year-old male patient, a policeman, that had since 2 days before admission tingling and numbness and also cyanosis in his foot. He was a special forces. He appeared with a phlegmasia cerebellar. He already had a cold limb with severe cyanosis, bad perfusion. We barely could feel his pulses. He had also acute tubular necrosis and hypertension, and his CREA and urea were already elevated as he showed up. As he was very thin patient, we were able to do an ultrasound, a normal ultrasound, and we could see the compression already. So here, as we can see, we are using CO2 CO2 angles to avoid the use of a lot of contrast. You can see here on the right side that the guide wire passes quite smoothly, and then we move forward here with the device coming proximally, and we can see here the device with a little bit of contrast. And as we have a lot of compression here proximally, I'm doing all the fine adjustments with the device without being worried about distal embolization. So we did the IVUS, we confirmed the compression, and then we did pre-dilatation, stent implantation, balloon, post-ballooning. We'd use the stent from BD Bar, the Venovo stent. We pre-dilated with a 12 by 40 balloon conquest, and we post-dilated with a 1660. And this is the result. Right after the procedure, we already find an improvement on the patient, and this is continuously felt in the upcoming days. So this is another patient, pre and post, also a very impressive result. I think that we were very happy with the result, and we think that in terms of inferior vena cava filter, which just Homeric and Thomas mentioned, and some people questioned, we think that it's important to take out the filter as soon as possible. In terms of patency rate, it impacts negatively. It also impacts relief of pain on a long-term basis. It also impacts relief of swelling, all negatively, and also impacts the freedom from ulcer. So we really believe that we should take the filters out whenever necessary, as soon as possible. So we think that in our single center experience, we think that the use of this device in acute settings of iliofemoral DVT resulted in a very high procedural success rate. We had a very low rate of complication. We found that it was a very safe device to use, very good and interesting patency rate of 92%, primary assistant. We know it's a modest number of cases, single center experience, but it brought us confidence to use it as our first choice. We are looking forward. We just got our ethical approval for taking part of the PMAX, so I'll join the guys hopefully in the upcoming months and try to clarify a little bit more properly this scenario. So I thank you very, very, very much for your kind attention.
Thank you very much, Dr. Bruno. In the meanwhile, maybe Dr. Thomas Heller is sharing his presentation. A quick question for the panel. You know, stents are still in the debate when we are talking about veins and mainly iliofemoral DVTs. So, quick question for you. When and what kind of stent do you implant during iliofemoral DVTs? Dr. Bruno, you want to go first?
Well, I'm a strong advocate. I mean, in about a year or two, we will be probably changing part of what we are saying now. We are treating a modality that is new in the endo scenario, so we are learning as time goes by a lot. So, for instance, we know now that we need to go big in terms of stents. We need to go long in terms of stents. Either you go big or you go nowhere. Either you go long or you better go home. So we would never, or we would avoid a lot to cross the joints, the femoral, the inguinal joint. But we know that in terms of patency, it's very important if you need, especially in chronic patient. And this does not reduce the patency; it actually increases the patency. So if you need, you better cross it. So those are concepts that do not apply to the arterial segment. So something very important is that we all lived, and I'm pretty sure that my two colleagues are more experienced and pretty much older than me. So they also experienced the cardiological stents in the arterial segment 20 to 30 years ago, before we had dedicated arterial stents. And for the same comparison, I think that we should use dedicated venous stents as much as possible. I do use Venovo from BD Bard a lot. I do use the Silver venous stent, and also the Zinus from Optimed. We could also discuss, if necessary, differences and particularities among their main indications, if they do have some. But as much as I can, I do use dedicated venous stents.
Okay, thank you very much for sharing this. Dr. Lefroy, for you?
Yeah, I totally agree with Bruno. I mean, the main thing is to use dedicated venous stents. So no one is better than over once. At that time, we now use Sinus Superflex from Optimed, and also Venovo from Bard. A stent which is very interesting also from Optimed is Sinus Obliquus for the iliocava level. But the main thing is to use nitinol stents and dedicated nitinol venous stents with large diameters, for sure, especially at the proximal port, to make sure that we restore the flow properly. That's the main thing.
And for you, thank you very much. Dr. Thomas Heller, would you like to comment on this as well?
Yes, I think this is one of the pitfalls of the ATTRACT trial, that they didn't use venous stents, and there are some specialties of these stents: the diameter, the flexibility. But another important thing is, before we use a stent, we should open up the vein. Because, and this is also in contrast to the arteries, if you have a plug in the artery, then it's, how to say, fixed in the vessel wall. If you have a fresh or an acute clot in the vein, it's not, it's inside the vessel. And if you use a stent, then the clot goes through the mesh of the stent inside the stent. So that's why it's important to use a device which cleans up the vessel. So sometimes we see a narrowing of the vessel, and this is not a clot, this is the thickening of the venous wall, because it's an inflammatory process. Then we might discuss if we need a venous stent or not. Romarek told us that the drugs will, and the time will do the job. So we should carefully discuss if we need a venous stent or not. But most important is, before we discuss about venous stents, we should clean up the vessel. We should have a vessel free from residual clots inside.
Okay, very clear, and thank you very much. I think we will leave another important topic after your presentation, Dr. Thomas Heller. This topic is about anticoagulation post-operative. I think we will start first with the presentation, if you don't mind, and then at the end we will answer also this question. Please, go ahead.
Okay. So can you see the presentation?
Yes, we can.
You can. Okay. Then let's talk a little bit about a different indication, because this is a clear off-label use of the Asperger's device, like in a pulmonary embolism. We try to remove portal venous thrombosis using the SPX device. Why? You
Just to
can
let
see
you know, Dr. Thomas Heller, you are sharing your screen, not only the presentation. It's fine for us, but if you prefer to share only the presentation, would be also okay.
Is this okay?
Perfect.
Yeah.
Okay, so why do we so? Because you know, if you have a portal venous thrombosis, it's like in the iliac or the femoral vein. There are some patients with a spontaneous recanalization, which happens very early, but there are a huge number of patients with no spontaneous recanalization, even not with anticoagulation, and they have a reduced 5-year survival because they develop portal hypertension, they have bleeding complications and splanchnic infarction, even if they are under oral anticoagulation, and they have to have anticoagulation lifelong. So this portal hypertension is the second cause of for portal hypertension in the Western countries, and we do have a lot of different reasons. You might have a tumor or a chronic inflammatory bowel disease, which causes or is the underlying cause for the portal venous hypertension. And we have very different symptoms. And I know from colleagues from China, they have a lot of portal venous hypertensions after liver transplantation. We didn't see it in our transplant center, but there are some messages from China where they saw this. And for us, this is the indication to treat the portal venous thrombosis. If a patient is symptomatic, and symptomatic means if the patient develops pain, or if he has ascites, or if he has impaired liver function. And our approach is that we set the patient under oral anticoagulation, and then we use the TIPS approach from transjugular. And this is also important because if you try to do thrombolysis in the portal vein and you use a direct puncture, a direct percutaneous puncture of the liver or of the portal vein through the liver, and you have the thrombolysis over some hours or overnight, then there's a high bleeding risk because the liver moves by breathing, and if it is a non-cirrhotic liver, then you might cut a hole in the liver and have bleeding complications. So this is the first case I want to share with you. You can see this is a patient with an acute portal venous thrombosis. This is a fitness trainer, a 50-year-old, and in the ultrasound you can see the head of the clot in the portal vein, clearly here, and also the superior mesenteric vein and the splenic vein is affected by the thrombus. And we, as I told you, we used the TIPS approach, a punctured the portal vein with ultrasound guidance. You see the catheter here is inside, and when we injected the contrast, you can see the portal vein is occluded, and the superior mesenteric vein and the splenic vein also. And then we advance the catheter into the splenic vein, and you see here are some splenic vessels visible. What we did then is that we advanced the 10 French sheath into the portal venous system, and we started the action with the Aspirex. We decided to use the Aspirex, not the Rotarex, because it's a venous system, and there are thin venous walls, and even in the mesenteric veins are not fixed or less fixed than the veins of the leg. And we cleaned first up the splenic vein, then we advanced the sheath into the superior mesenteric vein and started to clean up the mesenteric vein. And this is the final result. As you can see, The splenic vein is still patent. The superior mesenteric vein is free of clots, and also the portal vein. And there is this is like a Turner syndrome of the portal vein. Here is an underlying stenosis. This is the control. The next day, like in the common femoral vein, you can see a thickening of the venous wall. So there might be an inflammatory process. We did nothing else, and this is some years ago, and I met this guy 3 months ago. The vein is still patent, and what I interesting found was a underlying factor V Leiden mutation as a cause of a hypercoagulability. The second case is very interesting because this is a 39-year-old male patient. He underwent surgery because they thought that his pain in the abdomen is caused by cholecystitis. And you can see the right arrow here. We recognize it later on because this is the thrombus in the portal vein, but this is a pre-existing subhepatic cavernous transformation. You see the clot here. You can see the clot in the CT scan. In the MRI imaging. And we decided to use also the TIPS approach. As you can see here, the portal vein is totally occluded, but this is contrast in this subhepatic cavernous transformation. You see the clips after the surgery, and also in this case, we advanced the 10 French sheath into the superior mesenteric vein, started the action with the Aspirex. You can see the remaining clot here. And then we were able to get rid of the clots in all parts of the inflow into the portal vein. And this is the final result. And yes, there's no or less contrast in the right level lobe, but the cause or the reason for this is that the right level lobe is connected to this subhepatic cavernous transformation. So we cleaned up the portal vein and the left-sided intrahepatic portal venous system. And this is the last case because of the time. This was a patient we thought that he has acute portal venous thrombosis because where the red arrow is, you can see the contrast in the portal venous wall. You see the clot in the portal vein, in the superior mesenteric vein, and also in the splenic vein. And then again, we advanced after the diagnostic for French catheter, we advanced the 10 French. You can see it here. We cleaned, or we reached the splenic vein. And interestingly, we find collaterals into the gastric wall. So this is not an acute or a patient with an acute portal venous thrombosis. This is a chronic portal venous thrombosis. You see there are some stenosis. And for that reason, we decided, and the patient had, but acute, severe pain, acute ascites, he has elevated inflammatory blood parameters, and also an elevated lactate. You see, we reach the portal, the splenic vein, and also the superior mesenteric vein. And what we did is, first, you see the clots in the superior mesenteric vein. We get rid of the clot by using the 10 French in every case, the 10 French Aspirex device. And after that, we tried to balloon the portal venous system to get rid of all the stenosis that might cause an early reocclusion. And unfortunately, by ballooning, you see they're staying outside. So we have had a perforation of the portal vein. And for that reason, as you can see here, we inserted a Viator stent graft. And in the control, you can see the superior mesenteric vein, inferior mesenteric vein, the splenic vein, and also the main portal vein is still patent. But this is the only patient where we inserted a stent after the recanalization. Sorry, the presentation. Yeah, now it comes. So in between, we treated 5 patients. One was the patient with the acute portal venous thrombosis, one with the chronic, and one with the acute on chronic portal venous occlusion. In every case, we used the transjugular TIPS approach. We did first the diagnostic angio with the 4 French device and then exchanged to a 10 French device. In every case, we used the 10 French Aspirex and gave additional infusion via the 10 French sheet, because even with the 10 French device, it's possible to inject saline and contrast mixture, as Bruno Freitas mentioned. And we left only a 4 French pictic catheter as a control for the next day, because we were afraid to have a early re-thrombosis of the portal venous system, because we do not know about the flow in the portal venous system and the hemodynamics in the portal vein, or even in the supramesenteric vein. The follow-up examinations were performed by color duplex ultrasound, and the primary technical success were 100%. We have one severe complication. We have one rupture of the portal vein caused by, not by the Aspirex device, but by the balloon PTA, and we treated the rupture with a covered stent or a stent graft. We have had no bleeding. We have had, after the procedure, no new ascites or hemorrhagic ascites. We have had no pleural effusions. We have had no liver hematoma like we saw it in patients where we performed a thrombolysis of the portal vein. And we have had no vascular injury in the excess vein, the jugular vein, superior vena cava, or the right atrium, or the hepatic vein. So there were the cases I want to share with you. This is Isabella in Rostock, and thank you for your attention.
Thank you very much, Dr. Heller, for your very interesting presentation. This is an indication that is really, really fascinating to me. So thank you very much for sharing your cases. I think we are a little running late. So probably just maybe Ken, you told me you want to wave goodbye. You probably have other appointments before we go into a really super fast Q&A session.
Thank you, and thanks, Sergio. Yeah, unfortunately, I have to leave for another commitment now, but I just wanted to thank all of our experts here, Professor Laffoy, Professor Freitas, Dr. Heller, Sergio, and all the team who make these things possible. Thank you very much indeed, and I look forward to seeing you all for the next webinar coming in very shortly. Take care, everyone.
Thank you.
Bye.
Take care.
So,
God bless.
I think even though we are 10 minutes late, if you don't mind, and our audience will still be here, and I see that numbers are still very high, we will run a very fast Q&A session, if you like, starting probably from the post-op protocol for anticoagulation. I think this is a question that came up in the chat many times during this webinar. Would you, Dr. Heller, start with your protocol, sharing us what you normally do in your practice?
This is very uncertain. We discuss it on very often on scientific congresses, because we have, how to say, like a German way. So if we recognize a vein, and even if you place a stent, we try to use one of the direct oral anticoagulants, rivaroxaban or others, plus ASS 100 ml per day for 3 months. And the treatment regimen for with the anticoagulation is the same, like, or is described in the guidelines for patients with acute DVT. But there is a difference, and if you see the data from the venous stents, hopefully you agree me, then we have a lower patency with the new dedicated venous stents than in some very old studies performed with the wall stent. And maybe the reason is that in the old studies they used warfarin or vitamin K antagonists, and there's a difference between the new drugs and the warfarin. And the difference is that if you use warfarin, you have a therapeutic anticoagulation for half a year. And if you use the new drugs and follow the guidelines, then you lower the dosage after 1 week or 3 weeks to a prophylactic dosage. So it's really not clear which is the right way. In Rostock, we have a therapeutic anticoagulation for 3 months plus ASS 100, followed by prophylactic dosage for another 3 months. And then we perform follow-up ultrasound every 4 weeks, then 3 months after half a year. And if everything is fine, we stop the anticoagulation. That's our experience.
Thank you very much. Something you would like to comment, Dr. Lefroy? Otherwise, we have plenty of questions for you today.
Okay, maybe we can skip and then go on with other questions. Yeah.
Okay, so for example, here, since we were discussing with Dr. Heller, TIPS approach versus transhepatic approach, why this choice?
Because we use a 10 French sheath. And if you have a transhepatic puncture of the portal vein, and the patient is still breathing and the liver moves up and down, then and you have a 10 French sheath, then you might slice a hole in the liver. And when we start a procedure, we do not know how we end. So if we are not successful and we have a portal venous hypertension and we have a 10 French hole through the liver parenchyma, then we might have a bleeding. A TIPS approach is for us much more safer. So we have no bleeding outside. We have the bleeding inside the vessel and no blood loss.
Okay.
I agree with Thomas, Sergio. I think we've done some workshops here in Brazil, and the last one we did one case, and we preferred to do it. It showed up, and at the beginning of our small experience, we tried to do it transparietal puncture. I mean, it's hard. It's not so practical. It's potentially more dangerous. So since then, we are doing through a TIPS approach. Outstanding cases, Thomas. Outstanding.
Thank you. Thank you so much, Bruno.
Dr. Lafra, quick one. Post-op protocol in terms of mobilization of the patient, and I don't know if you apply a bandage on the leg and how long, for how long?
Yeah, the goal is to be able for the patient to walk just after the procedure. So whatever the approach, tubular or popliteal approach. So we ask them for walking, of course, and with stocking at the same time, of course, for at least 2 weeks. But the goal is really to be able to walk very fast.
Okay, great. Dr. Freitas, what about stents? So when you stent, first of all, if you have to overlap, how long the overlap? Then if you deploy first the proximal or first the distal, and then suggestion to avoid contralateral embolization, you know, with the stent protruding in the vena cava. Simple and fast questions.
Okay, so first, I would like to know if this webinar is being recorded, because if it would come back in about 2 years,
we can edit it after, you know.
You know what I mean? This can bring some quite, let's say, annoying scenarios. But let's say, well, the first thing is that 5 years ago, if we would talk about contralateral iliac thrombosis, this would be something that would sound quite new, I would say. But we know that this happens. We know that this happens. It can happen early in the post-operative scenario, and we know that some points can influence its appearance. And one of this is if you protrude the stent too much into the vena cava, particularly touching too much the contralateral wall. But those who are involved in the treatment of those patients, we know that it's quite easy to say avoid touching the contralateral wall, but it's not so easy to do it. In many cases, you end up touching, but the least you can touch, the better it is. So, like I told you, we do use stents and we deploy them from proximal to distal. So first the most proximal part, and then we move up to the lower level. We try to overlap classically, not more than there's no need to overlap more than 2 centimeters, I would say. It would be more than okay. I would say an overlapping of 1 or 2, it's okay. The main point is that you need to go as much as your occlusion comes. So if you need to go down, like Romaric just said, up to the common femoral level, please do it. In terms of patency, like I mentioned, inflow, it's the most important. And I'm sorry, I'm getting old and blind, and also deaf, and my memory is not so good. I lost your last question. Could you please?
No, it was like that. The overlap of the stent. Okay. If you should deploy first the distal one and then the proximal, or vice versa.
Proximal to distal. How far could you go? So first, you need to we need to remember that in sometimes May-Turner syndrome, it's not binary, whether you have or not. Sometimes it's a proximal compression. Sometimes it's a longer compression on the ipsilateral side, left side. There is May-Turner syndrome, which even compression on the contralateral side, on the right side. So we need to have a good previous angio-CT, a good previous study in order to evaluate how long the compression is. Another point which is important is whether you treat a purely virgin acute iliofemoral DVT or if you're treating an acute on chronic iliofemoral DVT. You can have patients with previously thrombotic moments, you have fibrotic material, you have an inflammatory response, but then you have a second or third episode of acute occlusion, then the patient decompensates. You do have a core track that, like Thomas said, you can clean it up. You should clean it up as much as you can in order to see what's going on, and then the treatment may vary whether you're treating a virgin patient or an acute on chronic patient. So this is also something different, I would say.
Thank you very much. Very last question for Dr. Thomas Seller about the portal veins. Do you think that the guide wire the 0.25 will have trouble with all that curves and turns? And another one, last one, do you think, do you find pharmacological thrombectomy useful in this scenario?
The guide wire is perfect. If you I think Roma talked about if you take care of the tip of the wire to be far or a little bit far away from the rotating head to prevent it from being cut off, then it's safe and it's stiff, but the tip is very flexible, and the flexibility prevents the mesenteric veins from perforation. So we saw no perforation by the guide wire, even not in the vein or in the iliac veins. The problem, the other question, the problem with anticoagulation is if you have this huge clot burden in the portal vein, the mesenteric vein, and the splenic vein. It's like Bruno told us. If you have no flow, if you have no inflow and in the liver, no inflow and no outflow, then the anticoagulation can't do the job. So you have to have inflow, and then you discuss with the gastroenterologist and the surgeons to place 2 catheters, one in the splenic vein and one in the mesenteric vein to get inflow, or you start first with mechanical thrombectomy via a catheter, and it's very time consuming and very difficult. You have to repeat the procedure to have flow. So if you use the mechanical thrombectomy, you open up the inflow you have open up the portal vein, so you have the outflow into the liver parenchyma, or in the cases of perforation, you insert a TIPS stent, and then you have flow in the complete portal venous system. If it is not enough. And that's why we leave the epictoral catheter into the portal venous system. So because we are a little bit concerned about having a early reocclusion, and if maybe someday we see a early reocclusion, then we will place a tip stent, repeat the procedure, place a tip stent to have also the outflow, like Bruno says in the iliac veins. You have to have inflow and outflow, and if you place only a lytic catheter, you can treat only one vessel and you have no flow.
Thank you very much.
That's my point. Hopefully you agree, Romarek and Bruno. Right?
I do.
Of course.
Okay, thank you.
Great. So I think, and I really thankful for your also patient. We ended a little bit later than expected, but really this webinar has been so much interesting, so many information shared with all our doctors attending, which were really a lot, actually pretty scary as well. So let me thank you once again from my heart on behalf of Straub Medical for your participant here. Thank you so much again to our audience, and really I hope to see you to our next webinar episode. Thank you very much again to everybody of you.
Thank
Bye-bye.
you. Bye-bye.